In this class, we're going over kind of the medical industry and how things work in the industry side. So I'm not going to be getting into our database or anything like that. That's a completely separate type of learning. I'm just talking about the institution of CMS and Medicare and Medicaid and all that stuff. So I just want to set expectations for you there. Before I begin, any questions, any grievances that need to be aired? Okay, it's always a scary question to ask. Okay, so this is our agenda for today. I will provide context for what CMS is and where it came from, and then I will go over each of the 5 programs that CMS oversees, and time permitting, we'll have a dance party. Spoiler alert, there's never enough time. So time permitting, we will watch a funny video, so hopefully that's a good consolation prize. So, context, broad stuff. CMS is part of the executive branch, and in the executive branch there are 15 departments, and within those 15 departments is the Department of Health and Human Services. And within the Department of Health and Human Services, there's about 30 agencies and bureaus and departments and stuff. And then CMS is one of those. So it is kind of a small sliver of the executive branch. These are the 7 programs CMS oversees. Medicare and Medicaid are the ones we're most familiar with and we'll probably spend the most time on today. But there's a few other programs that you may or may not be aware of that are managed by CMS. Incidentally, CMS, anybody want, I didn't mention this, but what does CMS stand for? Shout it out. Centers for Medicare and Medicaid Services, exactly. So we'll talk about these 7 things. For historically, again, we're talking about CMS, but also partially the Department of Health and Human Services. CMS, or what came to be known as CMS, was started in the New Deal with FDR with the Social Security Act. Originally, CMS and Medicare only covered like veterans, was only healthcare for a very small group of people. And then in 1965, LBJ broadened Medicare and Medicaid to be what they are today, which is a much larger umbrella, and we'll talk about what each one covers. And again, we're kind of looking at the things they own. So they started owning Medicare and Medicaid in 65. CLI and LTC were added a couple decades later, then CHIP, then HIPAA, then healthcare.gov. So that's kind of the order in which we're going to talk about them, is more or less the order in which they were introduced into CMS's purview. CMS administrator is appointed by the President of the United States and is confirmed by the Senate. Currently, it's Seema Verma. She was appointed by President Trump in 2017. I'm not going to say qualifications, but the reason she was appointed, her experience is that as part of the Patient Protection and Affordable Care Act, there was a Medicaid expansion. We'll talk about that at the Medicaid section. And she founded a company that helped states creatively implement the Medicaid expansion. So that's kind of her and her experience with the industry before she was appointed to lead CMS. Again, I talked about CMS as this small sliver of the executive branch. Just for some context, again, I'm probably too big of a fan of context, but sucks to be you. I'm the teacher. In the discretionary budget, the entire Department of Health and Human Services has $70 billion out of a trillion or so. And CMS only has about $4 billion of that. So it's a very small sliver of the country's discretionary budget. But that's just their operating budget. CMS is a very interesting department in that it has a very small operating budget, but it has outsized effects. So this is our entire US budget for 2019. There's 3 different types of things or categories that we spend money on. One is the interest in our nation's debt. The other is discretionary spending. That's like departmental budgets and things we can tweak. Whenever you hear about the Senate or the Congress in general debating over spending, they're talking about discretionary stuff. They're not allowed to debate over mandatory stuff because it's mandatory. So that's our entire national budget is mandatory. And of our entire national budget, Medicare and Medicaid combined make up more than discretionary spending, which means more than military spending. It makes up almost as much as Social Security. So CMS, despite being a tiny department, more or less administers the biggest or second biggest expenditure of your taxes that exists. So it's kind of a big deal. So we're going to talk about Medicare first. Any questions on the background of CMS and where it comes from and what it controls and all that fun stuff? Cool. So, Medicare. Let's talk about who it covers. So, Medicare covers a few different types of people. So I just want to make sure I don't miss anything. So, what most people know is that Medicare covers older citizens. Age 65 or older are eligible for this health insurance. It also covers younger people with certain disabilities. For example, my wife is blind. She is covered by Medicare. Or she could be. She's actually on our insurance because it's better, but that's a different discussion. And then also those with end-stage renal failure and ALS. So that's who qualifies for Medicare. And who participates? About 17% of Americans are covered by Medicare. By just this one program that is about 58% of CMS's budget, covers 17% of Americans. Of those, the vast majority are older individuals, but a decent fraction are the 9 million who fall under disability and end-stage renal disease and ALS. Medicare has 4 parts with a hidden 5th part. A lot of people, this is kind of what first piqued their interest in finding out more, because they're like, there's a Part A and a Part B and all that stuff, and it's very confusing. It's actually not that confusing, but probably nobody's ever explained it to you, which is why I'm here. So Part A was established when Medicare was first kind of released to the broader population. Part A is, we'll say, free, in that it's covered under, if you're eligible for Medicare, you don't pay for Part A coverage. You just get it. Of all of the parts of Medicare, Part A is the only one that is like that. A lot of people don't know that. That really only one of these items is completely taxpayer funded, we'll say. That's better than free. That covers very basic services. If you're admitted to the hospital, if after admission to a hospital, you are then sent to a skilled nursing facility, and for hospice care, that's what Part A covers. Part A also covers certain pharmaceuticals that are doctor applied. So if you have to go to a hospital to get this kind of prescription, like chemotherapy, stuff like that, which is technically a pharmaceutical, that's covered by Part A. But if you go to the drugstore and get some drugs, that's not covered by Part A. When you sign up, or when you were enrolled in Medicare initially, you are asked if you want to enroll in Part B. Part B you pay a fee for as a Medicare enrollee. You don't have to take it, but they structure it such that you're very incentivized to take it, because if you choose not to enroll in Part B when it's first offered to you, you can enroll later, but you have to back pay all your premiums up till when you were first eligible. So most people take B right away. It's not terribly expensive, about $100 a month to be eligible for Part B. And Part B covers outpatient care, so your doctor's visits, durable medical equipment like wheelchairs and respirators, stuff like that, and prostheses. Part B is more or less, I believe everybody kind of understands the difference between fee for service and then fee for outcome systems. Part B is more or less explicitly a fee for service. Like, something happens and you pay for it. There's no managed care part of it. It's all just very transactional. So those are the two initial parts of Medicare that were established. And then in Part C, a few decades later, a new part was added. And if you've been to the history of the second part of the history of medical of healthcare in the United States, you know that during the 90s, especially the early 90s and late 80s, we had the managed care boom, right? So that's when HMOs were a big deal. Basically, managed care is the alternative for fee-for-service, right? So when you have specific affiliations, you are able to coordinate care. And managed care, our plan, our definitive healthcare plan, is an HMO. It's a managed care plan. You can't go see a specialist without your primary physician being aware. It's coordinated care. It's meant to improve outcomes and lower costs. Who would have thought, right? Because you're not seeing people that you probably don't need to see, or at least not that your PCP doesn't want you to see. And the left hand knows what the right hand's doing. That's managed care. So what they did was, in '97, they created Medicare Part C, also called Medicare Advantage. If you hear Medicare Advantage, that's Part C. So what Medicare Advantage does is it layers on top of Parts A and B a managed care plan. So I'm not going to draw this, but you get it. So you have Part A. Because you're in Medicare, you have it. You've paid for Part B. Congratulations. Now, if you have A and B, you can choose to get Part C. And what Part C does is it gives you a little bit more flexibility. It gives you an out-of-pocket limit, which Parts A and B don't have. It gives you this kind of managed care network. Now, you pay for that, just like you pay for your HMO definitive healthcare. You're paying for Medicare Advantage. Ostensibly, if you do the math and you think you're going to have high out-of-pocket costs, it makes more sense to do Medicare Advantage. Not everybody does it. I believe a third of Medicare participants, 35% of Medicare participants are enrolled in Part C as well as Parts A and B.
What percentage?
35 as of 2018. And then Part D, for people who were alive and relatively politically conscious during the early aughts, Part D was passed and pushed through by President George W. Bush. There was lots of talk about the donut hole in Medicare. I don't know if anybody remembers that phrase. It was ridiculous, but it was evocative because I still remember it. And the donut hole is that we have hospitals, we have nursing facilities, we have hospice, we have outpatient, we have all this stuff. We don't have prescription coverage other than stuff that's administered by a doctor. And part of the downside of keeping people alive longer by being better at keeping people from dying is that typically people need more drugs as they get older, and they need more, pharmacy drugs, not doctor prescribed drugs. Again, that's a sign of progress. We just didn't factor that in because, people died younger in 65. What a luxury. So Part D introduced pharmaceutical coverage. Again, just like Parts B and C, you got to pay for this. It doesn't just come with things. Generally speaking, Part A, if someone only has Part A, it only covers about half, this is just from studies, it only covers about half of the medical costs that someone incurs. So you kind of have to get other parts, or you need to have coverage elsewhere. Medigap is the fifth part of Medicare, and the reason it has an asterisk is this isn't managed by CMS, but it's very integral to the concept of Medicare. So there's if you don't have, you're eligible for Medigap if you meet some requirements, but it's a private solution. So in the same sense that even if something's a private solution, you might not be eligible for it, right? If you want life insurance, but you're terminal, just because it's private doesn't mean you can get it. Same thing with Medigap coverage. If you are a person who is on Medicare, but doesn't qualify for Medicaid as well, or if you're on Medicare, but you haven't elected to get Part B and C coverage, or not covered by a former employer through COBRA, then you are eligible for Medigap. And basically that is just a completely private plan that works in conjunction with Part A. So another way of thinking about it is, so this is free, cost money, cost money, cost money. If instead of paying these $3 amounts, you would rather go completely private that's designed to work with Part A, that's the option there. Typically, private's more expensive than public, but private is more efficient than public, so it's a trade-off. So that's what Medicaid does. As far as percentage of our GDP, in case you're curious, all this stuff adds up to about 3% as of 2016. And these are more or less the participation rates. So like I said, most people who have Part A also have B and C. D is relatively new. That's not a representative, in Part D, it's not representative of how many people necessarily. That's just because it's so much cheaper. It just makes up a smaller dollar amount. So I want to make sure we all understand not just how these things work on the end side, but how does it work on the back end? How does it work from a business perspective, right? Because that's what we're in the business of healthcare, not the caring part of healthcare. I mean, we care, but Definitive cares. So this is how reimbursement works. And each part has different ways of working. So parts A and B, there is a panel of about 29 specialists who are affiliated with the American Medical Association. And they have this list of over 7,000 procedures. And they go through that list. I don't know how, so please don't ask. They go through that list and come up with 3 RVUs, or relative value units, for each procedure. And then those relative value units are multiplied by an economic factor and also a geographical factor to come up with the amount that Medicaid or Medicare is going to reimburse a provider for a service. And they update this, I believe, every year. Let me check. Yes, every year. So that's parts A and B. Part D is pretty straightforward. Honestly, Part D works almost the exact same way that prescription coverage works through a private payer like Blue Cross, because it's a collaboration between CMS, which is a payer, a pharmaceutical company, which is the one making the drugs for everybody, and a third-party sponsor, which is a pharmacy benefit manager, a PBM. And there are really only 3 PBMs that matter these days. So pharmacy coverage is more or less equivalent in Part D as it is in any private organization, as far as the reimbursement structure and the organization of it works. And then Part C is a third-party company who provides this Part C Advantage, Medicare Advantage. So that's just managed as if it's an HMO. But it's, again, managed to layer on top of this and to function as if it's in a partnership with CMS. Questions about that?
If Part D works so similar to everything else, why do you always hear that Medicare gets the best rates?
So the question was, if Part D works so well, why does Medicare get such good rates? Works so similarly. Bargaining power, right? If CMS is combined bigger than the next 3 biggest insurance companies, they just have a better position for bargaining. That's why. And last, but certainly not least, how do we pay for all this stuff? Because we certainly do pay for all this stuff. Part A, like I said, the user, the Part A enrollee, doesn't pay anything per month for access to it. That's entirely paid for by payroll tax. So it's a 2.9% payroll tax if you're self-employed. If you're employed by an employer like Definitive Healthcare, you only pay half of that, and definitive healthcare pays for the other half of that. And I mean, that doesn't quite cover all the people who are covered by Part A, but it mostly does. The rest is paid out of the general treasury. Parts B and D, so again, B is the outpatient care, doctor, stuff like that, and then D is the prescription drugs, are paid by a combination of premiums, because the people who have access to this are paying every month, and whatever the premiums don't cover, because they don't cover everything, is paid out by the general treasury as well. So this is that 680 whatever billion I was talking about. That's that. And then Part C, again, completely third-party oriented. They're their own companies. They need to be profitable on their own. We as taxpayers don't especially care about them from a financial standpoint. Whew, that was Medicare. I promise they get easier as you go on. I'm just laying a lot of foundation with that. Any questions about Medicare? All right. Medicaid. Luckily, if you know about Medicare, Medicaid makes a lot more sense. So who does Medicaid cover? Medicaid covers a combination of people who need it and who meet certain categories. And it's a combination of those two things. The short answer is poor people get Medicare or Medicaid. I'm going to make that mistake a lot. I mean Medicaid from now on, generally. So generally speaking, people who have income, lower incomes have access to Medicaid, but not making a lot of money doesn't solely authorize you or doesn't solely qualify you to get Medicaid coverage. You also have to belong to certain categories. And I'll give you an example in a second. There's an asterisk next to who's eligible, because Medicaid is a partnership between federal regulation, between CMS, and states. So each state makes its own thresholds and requirements and categories for who qualifies for Medicaid. It's completely state by state. The federal government does other things, but they mostly just match whatever the state gives. And if we thought there were a lot of participants under Medicare, there's even more under Medicaid. The reason there's a range there and another asterisk next to 73 to 76 million is because this is hard to get concrete numbers for, because again, it's not one centralized CMS gathering this data. It's each state gathers this data, and it's just really hard to get a solid number on this. And I mentioned before, like the secret Part 5 Medigap, that covers people who don't qualify for dual enrollment. Dual enrollment is if you're disabled or elderly and you meet these requirements, you're eligible for both Medicare and Medicaid, which is good because Medicaid is a little bit richer in benefits than Medicare. So if you're in that situation where you qualify for both, that's good for you. Well, you're not in a good position, but it's good for you that you're qualified for both. So that's an additional, and this is why this number is hard too, is because some of those 76, there's some people who are also Medicare and Medicaid. So this is why the numbers are a little bit fuzzy on the Medicaid side. But you get a feel for what that is. And so that's 23% of the US population. So between Medicare and Medicaid, we're at about 40%, 35, 40% of the US population whose health is in the hands of this little department with $4 billion budget. So let's give you some examples to make some of the stuff concrete. So when we talk about eligibility, we're talking about need and category. I'm going to go over both of these right now. So need is entirely based on the federal poverty level or federal poverty line. Here are the 2019 federal poverty levels. One means the left column is the number of people in your family, the right column is the FPL, and then the other columns are, I did some math for you so you don't have to do it on your own. So for a family of 5, if you're making $30,000 or less, you are below the federal poverty line. Again, this is 100%. So 30 grand is 100% of federal poverty level for a family of 5. Now, again, different states have different thresholds for what it means to need Medicaid. So some states, it's you have to be at 33%. You have to be at less than the federal poverty level to qualify. That's an example. I don't think any state's that low, actually. I think the lowest is, it doesn't matter. And in some states, you can be at 200% the federal poverty level, still qualify for Medicare. So again, state by state depends. And again, I want to reiterate, this is not arbitrary, right? It is more expensive to live in Massachusetts than it is to live in Kentucky, right? So this is useful. It's complicated, but it's useful. Here are a couple examples, again, between Massachusetts and Kansas. So this is where you see these little numbers here, these percentages are the need, and on the up top are the categories, right? So the whole reason we have Medicaid is because, because you can't afford insurance on your own, right? So what's interesting is different categories have different thresholds. So if you are, let's say, I'm going to give you an example. In Massachusetts, if you are a, we'll say, single father of 2 children, and you make, let's see, that's 133%, and you make, single father, 2 children, and you make $42,000 a year. Your children, assuming their ages 1 to 5, no, assuming they're below age 1, your infant basically is covered by Medicaid, but you aren't. If your child grows out of age 1, then they are no longer covered and you're not covered because you make a little bit too much money. So it's very situational specific who gets covered by Medicaid and who doesn't. So it's situational and geographical. And you can see this is an illustration of between the different states, the different numbers, right? So if your family makes 200% of the federal poverty level in Massachusetts, your newborn can be covered. But if you made the exact same in Kansas, your newborn's not covered. I'm not picking on Kansas. It's just a state I chose. So you understand what I meant before about a combination of need and category and, okay, cool. I've been told that understanding the 133% and the 500% and all that stuff is tricky. So I want to make sure we nail that because it comes into play in a minute. So what does Medicaid offer? We know who's covered now. Well, we know how to find out who's covered now. What it offers is basically all of Medicare's A, B, and D, meaning hospital, outpatient, and pharmaceuticals and prescriptions. It also covers things that Medicare doesn't cover, like nursing home care and personal care. It also covers emergency room visits, but it covers them kind of. It's not like part of your plan is emergency room visits. It's in our country, we have nationalized health care, believe it or not, despite what people argue. We have nationalized health care. Anybody can go to an emergency room and receive health care, whether or not they have money for it. It's very inefficient nationalized health care, but that's a different discussion. So if someone goes to the emergency room and doesn't have any money to pay for it, whose pocket does that come out of? Combination of the hospital and the federal Medicaid budget. What's the impact? Here's some staggering statistics. 60% of all nursing home residents are on Medicaid. Over a third of all children born in the United States are born covered in the Medicaid program. So again, very outsized impact for CMS. Also, depending on what category you're in, right, because this is category-driven in addition to need-driven, you also qualify for different benefits. So if you're disabled and on Medicaid, you don't necessarily get the same thing that an elderly person on Medicaid gets. And those are just some examples. I won't read. All right, now we're going to talk about how it works. Because now we know who's eligible, we know more or less what's covered. How does it actually work? So it is a partnership between federal and state, but it is state run. And states are not required to participate in the Medicaid program. Now, as of 1982, all states do participate in it, but it's not a law that a state has to offer Medicaid. And what happens is states are given flexibility. So they say, here's what Medicaid is, here's what the federal poverty lines are, and they're given those outlines that I showed you before. And the federal government says, you determine these requirements, and whatever you contribute to, we're going to match. And the government doesn't necessarily match one-to-one. That FMAP is an acronym for I forget what, but it basically is a formula that the government uses to say, like, we're going to match 100% of what Kentucky or Kansas pays and only 50% of what Massachusetts pays, for example. So it's not necessarily a one-to-one match, but it is a match structure. And so states get to set their thresholds because it's their budget. Even though they're being matched, they have to pony up the cash first. And that's why they have the different levels, because different states have different budgets. So as part of the Affordable Care Act, this is where that federal poverty line I was talking about, that understanding of 100 and 133 comes into play, is right here. One of the things that the Patient Protection Affordable Care Act did was it increased the lowest threshold to be eligible for Medicaid. So the federal government said, okay, Medicaid now has to be available. It said this to all the states, right? Because it's state run. It says to the states, okay, Medicaid now has to be available to anybody, at the very least, who's at 133% of the federal poverty limit level. And states can still go above that. Great. Like Massachusetts is at 200, so Massachusetts wouldn't have to change anything. And so the federal government said, if you want our match, you have to do this now. And that was part of the original Affordable Care Act legislation. However, I believe a year and a half later, the Supreme Court in Sebelius ruled that that's not legal. The federal government can't do that. Because basically what happened is the federal government initially said, you do this, it's up to you, and we'll match. And you have freedom to make it work for your state. And then states said, okay, trusting that that was the deal. And now the expression that was used in the write-up, the legal write-up, is that the federal government now had a gun to their head saying, you know this thing you rely on? As Darth Vader says, the terms of the agreement have changed, and you have to accept it or I'm going to pull the trigger. That was how the Supreme Court interpreted it. So the Supreme Court said, you can't just unilaterally change the deal. You can increase your match if you want. As the federal government, you can do that, but you can't all of a sudden say your budget's screwed because we want to increase the FPL or the minimum coverage for Medicaid. So that's what Sebelius happened. That was 2012. Questions about that? Okay. So because it was deemed by the Supreme Court to not be required, not all states took on the Medicaid expansion. And part of the Medicaid expansion was the federal government said, the gap between what you covered before and the 133%, you don't even have to pay for that full gap. We'll pay for, at first, 100%, and then they'll taper off to paying 90% of the difference. But not all states agreed to do that. So currently in 2019, there are 36 states plus District of Columbia that do it. The three most recent implemented or will have implemented by April are Idaho, Utah, and Nebraska. And I wrote Montana is going to have an interesting 2019 because last year there was a ballot initiative among Montanans to determine whether or not to continue the Medicaid expansion. And that ballot initiative failed. So unless a different initiative is passed, Montana will be the first state to undo the Medicaid expansion of 2010. So it'll be interesting. There's actually, if you're interested in politics and let's say money in politics, you should read up on what happened in Montana last year. And that's all I'll say. All right, questions about Medicaid? Medicare and Medicaid are the two big ones. I know we spent a lot of time on them, but it's because between them, they're about 90% of what CMS spends. Clinical Laboratory Improvement Initiative, or amendments, these were passed in the late 80s. And basically, CMS oversees quality control for clinical laboratories. Because before the 80s, there really wasn't any. It's weird to imagine, but healthcare is, as what we know it, is still only about 130 years old. So we're still figuring things out. And it used to be the case that there was basically no replicability. If a thing worked in lab A, it might not work in lab B. And so the CLIA created requirements that you have to follow in order to qualify, in order to get funding and to get authorization for what you're doing. And they also do quality control. It's not a huge part of what CMS does, but they do it. Long-term care quality standards, very similar. When was this? 1989, also late 80s. Basically, same thing. Establish a series of qualifications, and they're randomly inspected by CMS representatives. They also created structures that, again, didn't exist, where if an employee of a long-term care facility was doing something shady, they created reporting structures for that, which didn't really exist before. I don't know how many people have. I can't remember the movie name. John Cusack holding up the boombox. Say anything. That was late 80s. That was during this time, and a big part of the plot of that movie was an older gentleman who took care of older people stealing from them. So it's an interesting part of the times in that movie. So anyway, LTC quality standards is the fourth element, and that's something that CMS manages. CHIP. So CHIP was passed in the early 90s. Bill Clinton pushed to get universal health care passed. He failed, but this is kind of the compromise, one of the compromises that he walked away with, which is CHIP. And CHIP deals with this problem of families that make too much for Medicaid, but don't have enough to get private health insurance, which is a very real thing, as we just saw with federal poverty levels, right? If you're a family of 5 and you're making 133% of the federal poverty level, you're still only walking away with 35 grand. I couldn't afford my family's premiums, even with Definitive Healthcare's help, at 35 grand. So it said, okay, for those families, we're going to cover your children. And again, there's need requirements and stuff like that. But that's what CHIP is. And CHIP is a partnership with states. And states can choose whether or not to have a separate CHIP program or to roll CHIP into their Medicaid. Most states roll CHIP into Medicaid. So basically, instead of having a separately administrated CHIP program, which is costly and blah, 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 they basically were able to take the money and change their thresholds for those children levels, which is why pretty universally the children thresholds were higher than the adult thresholds because they have CHIP funds helping them. Sometimes it's called SCHIP, whatever. And CHIP was a big deal. Lots and lots of kids covered. Biggest expansion since '65 when Medicare was introduced. As of 2017, about 9.5 billion or million kids are covered by CHIP. So again, this is the weird in-between of families. So the parents may or may not have health insurance. The kids have it through CHIP. And just for reference, this doesn't necessarily mean anything, but this is just which states have the most participants. And it's not shocking. The most populous states have the most participants. Pretty standard. This isn't per capita or anything. HIPAA is the I think sixth thing that CMS covers. Everybody probably knows HIPAA as the privacy law, but really of the 5 titles, privacy is only one of them. Most of what HIPAA does is covers. It's called the Health Insurance Portability Act. So the first thing is portability. So when you leave a job, the ability to get COBRA and to continue your health insurance between jobs, that's thanks to HIPAA. Also, if you join our plan, as long as you were covered from a previous employer or from our plan, we can't exclude you for having a previous condition, a pre-existing condition. Now that's more or less irrelevant after the Affordable Care Act was passed, but for a couple decades that was a pretty important aspect. Also, it allowed, which is, this law allowed it, but it's still often battled in legal proceedings. It allowed employers to charge its employees different amounts for healthcare depending on whether or not they use tobacco and their body mass index. For instance, at Definitive Healthcare, we could say, you know, single healthcare is free, but if you're a smoker, you pay $50 a month. And A, that's to encourage health. B, it's because the reason other than inflation and general expenses going up, the reason a company's health plan goes up is by how it's used and how it's accessed. So if everybody in the company is healthy, then our costs don't go up. So it saves the company money and saves the individual's money. So there's a business incentive for a company to do that. We don't do that, by the way. Title II is the one that's all about the privacy. So that's, it simplified things. It introduced the concept of PII or PHI, which is personal identifiable information and personal health information. It also introduced unified NPI numbers that started in HIPAA, which was 96 or something. Before then, there were no NPI numbers. And this is where HIPAA gets its teeth. So if someone has access, regular access to PII or PHI, someone like, for say, your HR director who has all of your health insurance information and Social Security information, and I could probably get your claims information from Blue Cross. If someone is abusing that, there are serious penalties. So I'm taking a bullet for you guys if anything happens. And the penalties aren't just malicious. Like if I make a small accident that is anywhere from I was unaware to I was willfully negligent, I could be charged up to $50,000 per infraction and go to prison. If I willfully make a change, make an infraction, like if I sell your information or divulge, this counts as willful. If I know that one person is dealing with cancer and I tell someone else, that's a willful infraction, and I could get fined up to $250,000 and up to 10 years in prison. There's a scale, but those are the maximums. So that's HIPAA. HIPAA's no joke. Part 3 of HIPAA sets the rules for, at the time they were called medical saving accounts. Now they're called HSAs, health saving accounts. They've evolved a few times over the years. It set up the rules for how they're governed, who's eligible, what the tax breaks are, and so forth. Enforcement, again, adds teeth to Section 1, which is the portability part, not the privacy part, and also introduces the notion of COBRA, which we talked about. And then Title V is all about the finances of it and how businesses, what can businesses claim as exemption from for tax purposes. So that's HIPAA. It's actually a pretty involved thing. Most people know about it because of the privacy, because that's the scariest part of it. But it really is the reason that you're able to have insurance between employers. And it's the reason up until 2012 that when you went to a new employer, you were guaranteed to join their insurance plan. Because before then, the employer could say no because you're sick. And last but not least is healthcare.gov. So another part of the Patient Protection and Affordable Care Act was by the end of the year 2013, this website would exist that allowed people to enroll in health insurance through a market. Basically, the idea is to improve competition, and it's great. States were encouraged to set up their own exchanges for lots of reasons. A, because it makes more sense, because the facts on the ground are different in different geographical areas. Another element is that different states, by law, medical insurance can't be regulated across states. Each state has to have kind of its own entity regulating each state's medical insurance. That's why there's a Blue Cross Blue Shield of Mass and a Blue Cross Blue Shield of Rhode Island and stuff like that. Anyway, so states were encouraged to do that. Some of them did, some of them didn't. In the same way that some chose to accept the Medicaid expansion, some didn't. Lots of reasons why, doesn't matter right now. So healthcare.gov was created for people who were in those states that chose not to create an exchange so that they could have an exchange they could access. And CMS manages healthcare.gov. It had a very shaky rollout in October of 2013. Largely repaired by December of 2013, but it's a specter that still follows it today. And more or less, it's a non-entity at this point. They've ironed out the bugs. It's mostly a maintenance thing, and it only really comes into effect during open enrollment, which is end of the year to the first month of the year usually. So healthcare.gov only really matters a few months out of the year, unless someone has a qualifying event, and that's a whole thing, but that's the exception rather than the rule. A big reason that healthcare.gov existed, in addition to giving people access, was that part of the Affordable Care Act was that by 2018, if you didn't have health insurance, you were going to start paying a penalty. So in addition to being generous, you had to give people a way to get access to health insurance. As of last year, that penalty has been eliminated in the Tax Act of 2017, but right now we're back in 2013. So that's healthcare.gov. That's the last thing I wanted to talk about.